Welcome everyone to today's program. I am Carrie Pallardy with Becker's Review. The program will begin with the presentation. We will have a question and answer session following completion of the presentation. You can submit any questions you have throughout the presentation by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during this time. You will receive an email within about a week following the webinar that will include instructions for how you can download a copy of the presentation. You will also receive a follow-up email shortly after completion of the program. You can submit your feedback or any additional questions at that time. This email will not include the presentation. It is now my pleasure to introduce today's presenters. Adria Grillo-Peck brings more than 28 years of clinical experience to her current role as the Vice President of Graded Care Management at the Indiana University Health System. She is responsible for the strategic vision and priorities for the IU Health System's integrative management, working collaboratively with senior management to build safe positions of care for patients. She has direct oversight for the Academic Health Center with responsibility for planning, directing, and coordinating initiatives around growth, quality, patient safety, customer service, physician integration, and consistency of practice for the integrative care management service. Gina Intinarelli is the Executive Director of Population Health and Accountable Care. She is responsible for the direction, creation, planning, implementation, and evaluation of many large-scale clinical and operational programs and initiatives at UCSF, including sepsis surveillance, hybrid transitions of care, e-consults, medical homes, complex care, population health analytics, business intelligence, and bundled payments. She also has more than 25 years of direct clinical experience as a care nurse. She has earned both a master's and PhD in health policy from UCSF with expertise in phenomenology and organizational behavior. As a co-founder of Cipher Health, Alex Haynos has led the company through significant growth since inception. Alex plays a key role in business development by identifying and expanding strategic partnerships and initiatives for the company. Additionally, Alex oversees all aspects of steady-state operations, having managed hundreds of client implementations. Prior to starting Cipher Health, Alex searched outcomes and effectiveness at Weill Cornell Medical Center in New York and worked on the development of a physician tracking database at the Hospital of University of Pennsylvania. It is now my pleasure to turn the floor over to Alex to begin today's presentation.
Based on the fact that we have nearly 1,000 registrants, I think that it is safe to assume that everyone did not show up just to hear me talk, so I'll do my best to be as brief as possible. Healthcare has changed significantly over the past few years. The shift away from fee-for-service to various value-based models has been the driving force behind many of the changes in the healthcare industry. Whether it be VBP, CAPS incentives, or bundled payment programs, health systems have worked to reform care delivery with novel advancements in technology and a redesign of their workforces. Much of this shift has been aimed at putting the patient at the center of care delivery. However, such dramatic transformation requires a number of strategic changes, and these changes are what we'll be discussing today. To that end, let's get started and hear from the folks actually responsible for implementing all of these changes. So what I'd like to hear first is, what types of programs are you currently implementing or planning to implement to improve patient health outcomes and enhance the quality of care? And why don't we go ahead and get started with Gina.
Great, thank you for having me, Alex, and hello everyone. I'm glad to be here. So we've had the good fortune at UCSF of being able to be involved in many of the programs that you see on your screen. So I oversee the Population Health Department. For the past several years, we have been working on complex care. So we take care of very sick patients that have both chronic multiple medical conditions along with a lot of psychiatric diagnoses, and we have implemented a program where we use both care navigators who are highly trained in health coaching, and we use nurse practitioners and social workers, and we've just recently added a psychiatric NP to our team. We have just recently published a paper on this model, and that we have found that using intensive home-based assessments with a lot of outreach and high-touch coordinated care with this patient population, we have been able to significantly reduce emergency room and inpatient visits in our most complex care group of patients. The other program that we have done over the past few years is really looking at our transitional care. I think everyone is trying to find the ways to do this in a very organized and fashion that really addresses the needs of the patients in the transitional area. You'll later hear how we have used some of the Cypher products to do that, but essentially at this point we have several programs where we follow patients anywhere from 2 days after discharge, and that is for every patient at UCSF, up to 90 days post-discharge for those patients that are in our bundled payment programs. Along with that, we also have care management teams, and we are beginning our foray into looking at patients with chronic disease, depression and anxiety, and using a model, again, using very similar staffing model to do high-touch outreach to make rapid improvements in depression and then therefore chronic care management, self-management skills for the patient. So we're really excited to be involved in all of these innovative programs, and really the patients have really embraced this extra care that delivery systems often haven't, without a value-based business model, have not been able to offer patients. So we're very excited to be in these kinds of models.
That's perfect. Thanks so much, Gina. And Adria, how about I pass it over to you?
Good afternoon, everyone, and thank you also for having me on the call today. I have been with IU Health for almost 2 years now, and since I joined, we have implemented several initiatives trying to address mainly length of stay management and readmission avoidance, as well as looking at patient satisfaction initiatives. So some of the things that we've implemented are we have an interprofessional discharge huddle that meets on a daily basis where we review the plan of care for the day and for the stay, and really start that discharge planning as early as possible in the patient's admission. We have also implemented a follow-up appointment program so that we actually have clerical individuals that are scheduling patients that are at high risk for readmission. And those appointments are scheduled within 5 to 7 days of discharge and then placed on the electronic discharge instructions. We have also implemented a meds in hand program, so we partnered with our pharmacy staff to try to get patients the meds that they need prior to even leaving our facility. And although we do still have some improvements to make there, we're at about 46% right now. We also have a Care Alliance collaborative where we have partnered with facilities, post-acute facilities within our area, making sure that they too are delivering the highest quality of care. So we look at readmission rates, we look at Department of Health ratings, CMS ratings, and then really partner with them and look individually doing root cause analysis on those patients that are readmitted from each of those facilities. And then most recently, in November, we actually implemented the automated callback program, which I know we'll be talking a little bit more about.
That's perfect. Thank you so much, Adria. And hearing you both talk, you both have accomplished so much and instituted so many unique and novel programs. I'm wondering if you could each, respectively share, what are some of the results that you have seen since implementing these programs? And why don't we start with Gina again?
Okay, sure. So I think I had mentioned that we had seen some reductions in ED utilization and inpatient admissions. I think, again, we are in the early stages of evaluating our results. I think more is what we have learned. So what we have learned is that the intersection of doing transitional care work really needs to address the social determinants of health, and really our patients oftentimes have very fine medical treatment plans, but really what we have to do in healthcare is understand how we help patients manage their healthcare better. Another really important learning that I would say is a result of these programs is that we've also learned that most outreach and care management programs rely on nursing, skilled labor and nurses are a very important part of the team. But I think that what we have learned in order to do this in a fiscally responsible way, that we are able to use other types of staff, and indeed the patients really embrace these other types of staff. So like many organizations, we are using a healthcare navigator role, and I know that a lot of organizations would be interested to know about this role. So these are people, there's a huge workforce out there that wants to get into this kind of work. So there are people who have undergraduate degrees who are very interested in working in healthcare but may not have a clinical license. We have trained them in motivational interviewing, health screening, health coaching, and in fact, they form very solid and important relationships with our patients, different relationships than the patients form with their physicians or nurses, and have had a huge impact on our results in lowering hemoglobin A1C. We're beginning to capture patient-reported outcomes for healthy days and the patient's experience. So I think that's a really important result that we've learned from these programs, that we have to think differently about the workforce that we need to do this care, and how to build teams, and then how to have a platform, which is what we have used with Cypher, to be able to communicate across these teams and to ensure that everybody is working at the top of their skill set and that they are working together as a team. So we've learned a lot of important lessons in that kind of work. And then finally, some of our early results with our bundle payment, we were early on in the bundle payment work for orthopedic surgery. We've seen both an increase in patient experience. Patients happen to like it when you take an interest in them and follow them for a long period of time to check in on their welfare. And then secondly, we've also seen an improvement in readmission reduction. Because of that high-touch outreach, we're able to mitigate problems before they blossom into the need to go to the emergency room or be admitted. So I think those are some of the results that we've seen within just a few years of implementing these programs.
That's perfect. Thanks so much, Gina. And it's great to hear not only the results, but also the lessons learned from trying out some of these programs. Adria, how about the same question for you?
So two of the things that come to mind are first, I talked a little bit about our follow-up appointment program. At the beginning of, let's see, it would have been January of 2015, we were having our case managers actually make these appointments for patients. And obviously, with their heavy workload, it was something that was always falling to the bottom of their priority list. So at that time, we were scheduling about 13% of appointments for our high-risk patients. We looked at a process improvement where we are actually engaging with our Care Alliance department, and we have clerical staff over there that are actually making these appointments for patients now. So the case manager sends over a referral to our Care Alliance, and then the clerical staff picks it up, schedules the appointment, and then places it on our electronic discharge instructions. So since doing that, we've increased from 13% to 85%. So we're really pleased with those results, and our no-show rate is actually pretty low. The other example is around the Cypher Health Voice program that we implemented in November. So prior to implementing the program, each of the patient care units were kind of doing their own thing, where they were using nurses from the unit, and it was the one more thing that was added to their day. So a lot of inconsistency, and their reach rates were anywhere really between about 8% and 60%, and knowing that it was an additional workload for our nursing staff. So since we've partnered with Cypher Health, we are having a reach rate of about 75%. So really pleased with those outcomes. And although we don't know the impact to our readmissions as of yet, since it's a lagging indicator, we believe that doing the bundle of programs that I talked about earlier is certainly making a difference in our readmission rates. We are a tertiary referral center in downtown Indianapolis, and so for our Methodist Hospital, our readmission rates are about 8%, and at University, which does a lot of the very complex bowel transplant surgeries, our readmissions are about 14%. So although at University we're still not where we want to be, we are certainly making improvements there.
Perfect. Thanks so much, Adria. I really appreciate that. And during both of your responses, I heard each of you specifically reference the human side of care delivery and how your own human capital needs have shifted in order to meet these new models. Here at Cipher Health, we firmly believe that without team buy-in, it is impossible to drive lasting improvements. We not only develop products to empower healthcare professionals, but we also have a strong focus internally on team and culture. I believe it is for that reason that we were named as Modern Healthcare's #1 company to work for in 2014 and the #2 company in 2015. Aside from my own experience, there are countless studies that demonstrate the positive impact that staff satisfaction has on the patient experience, as well as patient outcomes. So really what I'm interested in hearing is, what steps have you taken to empower your team and enhance employee morale? And this time around, why don't we go ahead and get started with Adria?
So I think probably the biggest indicator is really involving the staff and having a shared governance model. It was one of the things that I implemented when I came to IU Health. Obviously, there's more buy-in, there's more understanding if you engage the staff in the decision-making and any process improvement measures that we make. So socializing ideas with leadership as well as staff and physicians is very important. We have an employee engagement teams that are actually working with leadership, and so that they are verbalizing to us what's most important to them, what makes them want to come to work every day, whether it's retention and recruitment issues or if it's around practice issues. So we all work together to try to focus on that. I think the other thing is just letting the staff be part of the solution. So again, I think it helps with buy-in. I think it helps with understanding. So, a couple examples that I can give around that was we actually had one of our staff members design the flyer that we used for our callback program that our patients receive. So it was, a contest around designing the best flyer, which was really fun for the staff. There was also a suggestion to add that the patient would be receiving a call to our electronic discharge instructions. So that was something that came directly from the staff. So again, I think it's just getting buy-in and having them understand the process.
That's perfect. Thank you so much, Adria. And Gina, how about the same question?
Yeah, so this is a very good question and something we often don't think about sometimes. But I think the way that we have approached enhancing our employee morale is several ways. Well, first of all, I think we've enabled them with the technology to be able to do their job. So, for example, when we were doing outreach calls for the phone call program, there was no easy way to keep track of which patients need to be called. They were keeping Excel spreadsheets. They were having to manually make those calls, leave messages, and that was very frustrating and not really a good use of a highly skilled nurse's time. So I think putting the right technology and making it easy for them to be able to focus their skill set on what they want to do, which is take care of patients, has really boosted their morale. Secondly, I think that we've also given them the ability to be able to make decisions around what kind of service recovery we want to do for patient experience. So one of the questions that we ask patients is how satisfied they were with their stay at our organization, and one of the issues was that that's a hard job, because when you have to listen to patients complain about what happened and try and do service recovery, they were feeling very sort of hamstrung on how they could make that better. So we helped them both with having a formal relationship with our patient relations department so they could work with them very closely. We trained them on how to do this work. And again, we recognize that this doesn't always have to be done by a nurse, that a nurse's skill set is really meant for doing assessment, symptom management, medication review. And so we also added a navigator to our team who very much wanted to do this kind of work and do outreach with patients. So it empowered them to use their skill sets at their fullest ability. And then lastly, I think what can't be underscored is the time and training to build teams. So in order to do this work, we have to think of healthcare differently. So for example, all of our team has been trained in motivational interviewing techniques, and this is a very different way of interacting with patients and very different than many of us have been trained traditionally in healthcare. So I think investing your time in the team to train them, to have the ability to test those skills before they use them on patients, and really investing that kind of infrastructure and resources into your team is really important. So I think those things have gone a long way. We have a great dynamic set of people, and they're really happy to be doing this work and really excited to be in this innovation field.
No, that's perfect, Gina, and thank you so much for that. And to both of you, you seem to be doing a number of different, or kind of employing a number of different initiatives in order to kind of boost the overall employee morale, make folks feel as if they're part of a team, really, leading the charge. So this next question might be a little bit more difficult because you're all doing so many different things. But let's say that you're starting from scratch. Let's say that it's day one. What do you feel is the single most important thing you can do or that you will do to boost employee morale? And Adria, why don't we start with you for this one?
Actually, that's an easy one for me because for me it's all about relationship building and how do you engage with your team. So looking at, being present in their work, surrounding and listening and following up on any issues that they bring forward, I think that is the most important thing that you can do as a leader.
That's perfect, and that's why you're the panelist and I'm the moderator, so that's fantastic. So thanks, Adria. Gina, same question to you.
Yeah, very similar along those lines. I think as you get involved in innovations work, the most important thing we did was really have the staff be part of the design team. So they helped design their own workflows. They had opportunities for feedback to change things, and things change rapidly. They had the opportunity to work with each other and understand each other's skill set. So I think giving people the space, the time, and the permission to be involved at the ground level. And I know some organizations are very top-down. It takes a little bit longer to do it this way. Sometimes it's easier to have sort of a top-down perspective. But in the long run, the engagement and the commitment that you get from your employees by allowing them to help design their own work and come up with the solutions that work for them, I think is probably the most important thing that we do, not only to boost employee morale, but to actually have the programs work because they bring that sense of pride and commitment and excellence to the work because they've helped design it themselves.
No, Gina, I think that's a really good point. I think that's a guiding principle here at Cipher Health, that the best ideas don't always come from, the executives or the founders of the company, but they come from all different aspects of the organization. And what's really, really difficult and admirable that you've been able to achieve this is to create the structure where you can elicit good ideas from employees and have everybody be involved in that process. It's really critical, I think, to ensuring that everybody has that type of team cohesion. So thank you again to both of you guys for sharing on that front. As we're talking about employees and, as we generally demand more and more from our employees and as patients expect a greater level of connectivity with their care providers, the role of technology in healthcare grows in importance. As technology is integrated into nearly every aspect of our lives, it is vital that we recognize its role in enhancing the patient-provider relationship. On the slide, you'll see that currently 79% of healthcare extenders who use apps report that technology improves the quality of interactions with patients. The goal for healthcare tech companies and the goal for healthcare providers as well should be to ensure that over the coming years, that statistic moves to 100%. So, given the increased importance of technology in the healthcare arena, how is technology playing a role in the changes and programs you are implementing? And this time, why don't we go ahead and get started with Gina?
Okay, I would say that technology is critical in allowing a better reach of your skilled employees. So, for example, We've implemented using the Cypher phone call program. This has made a huge difference in our ability to reach many more patients within the specified time frame that we think is of high quality, to understand which patients need to have a nurse calling them back and helping them with their critically important transitions issues. And without that technology, we would never have been able to reach the amount of patients, the scale, or the quality of patients, of quality care that we're able to give because of that, and frankly, the cost. So prior to implementing the phone call technology, doing this work manually was costly because it was costing us about $90 per completed call because we had nurses doing this work, and we were not able to meet any of our metrics around, are we calling patients in 48 hours? Do we know exactly what patients need? So the technology is really just a tool to help put your skilled nurses and other team members into closer contact with the patients. And I think what was also very surprising for us with the technology is how much patients will embrace this, because if they know at the other end of this technology they have someone who can help them and answer their questions, they're very willing to embrace all kinds of technology. And I think there's also a misnomer that older people don't embrace it, or in fact, our over 75 population uses this technology better than anybody, and their compliance with following through on either the phone call program or any of the other outreach telehealth is amazing. I think we've all been shocked to see what kind of uptake this has had. I think mainly because in healthcare we're still a little old-fashioned when it comes to technology, because we know that the human touch is really important. And what I tell my team is this is still the human touch. It's just that it allows us to do it on a bigger, more efficient scale and really put the skill set where it's needed at the time it's needed. And we wouldn't be able to do that otherwise.
Gina, I think that's great, and that hybrid approach is really important. I think it allows you to kind of engage with more members of the community, engage with more patients, and still let your staff members practice to their license. So thank you very much for that. Adria, same question. So how is technology playing a role in the changes and programs you are implementing?
Well, I would echo what Gina said as it relates to our callback program. I know that, when initially I talked about an automated callback program, it was really a turnoff to people. But once they actually saw how customizable it is, it's actually been received very positively within IU Health. I think technology, as a whole, obviously allows us to work much smarter so that we really are focusing and prioritizing on, those patients that are at greater risk. As I mentioned earlier, when we were doing the manual callbacks, our reach rate was very poor. There was really no standardization in terms of who's high risk and who are we calling. There was no mechanism in terms for the patient to call back into us if they had questions or concerns. So that's really allowed us to reach a greater population and really focus on those at greater risk. I think the other thing is just the whole analytics piece and the report, so that we have a better handle now than we ever have on where our opportunities are. And that's actually what's going to be most impactful in terms of how we drive change in the future. So, I certainly understand the generational differences, but as Gina alluded to, our older population, my mother and father, they both have a smartphone and know how to use it. So I think we're going to see more and more of that, looking at, downloading apps on our smartphones. And then the other thing that we looked at through our Cypher Health program is actually texting versus callback. So for our OB population, we are actually having text messages sent to that population. Then we met it's the younger population, and that's how most of the younger generation communicates, is through texting as opposed to a phone call.
That's perfect, Adria. And I think those new mothers probably appreciate not having a ringing phone if they're home and trying to let their newborn sleep. So that's really perfect.
Absolutely.
So the next question to kind of work through and understand is, how do you make sure you're choosing the right technology for your team? Purchasing, patient-centric technology. Adria, you mentioned apps. If this was 2005, 2006, 2007, none of this existed. So that means the underlying infrastructure, either through procurement or through some or other components of a healthcare system, probably aren't there. So, how do you guys go about choosing the right technology for your team, knowing how important the people are to actually executing any of these projects? So with that question, why don't we go ahead and get started with Gina?
Sure. So I think this is a huge learning curve for our organization. So there's several ways that we decide which is the right technology. So first of all, we have to understand what is the need, and then what is the technology we really need. I think sometimes we get a little caught up in this idea that technology is going to solve anything, and I have a mantra that the technology can't exist on its own. And in fact, if you look at any technologies that don't have a concomitant human attached to them to be able to mitigate problems and be able to help the patient when they identify, then they really actually don't work very well. And I think that in this space, it's hard to know which one you're choosing that is right. But I think the best case scenario is if you have the opportunity to test the technology first to see if it works for you, but to really understand what it is that you're going to use it for, and how are you really going to leverage it for the patient. What I think the other part too, though, that we don't want to overlook is what is the technology, and maybe this is what this question is not so much for the patient, but what about the technology for your team? So we are an Epic shop, and we've been on Epic for quite a while, and Epic does not allow the platform functionality to be able to communicate easily when there's several different team members taking care of the patient. And so, and it's really critical because our team members, our navigators are embedded in primary care, our NPs and social workers are out doing home visits, the psychiatric NP is in a centralized location or maybe in one of the clinics seeing a patient. We have a physician medical director that could be available to help with consultant work. So having technology that also helps the team work together virtually is really important, and actually been a very difficult bar for a lot of technology companies to overcome. So when we look at what we want, I would say that most of the time when I am approached by technology companies to look at their product, I will not even look at anything that doesn't connect back to a human being, because in the long run, technology on its own will not solve the problems with patients. I think technology that's smart, that's integrated, that's easy to use, that's customizable is the technology that we have sort of geared ourselves towards. And when we look at other companies that approach us with their different, so for example, we have another company that we're looking at that has an app on the phone that reminds patients to do things. But again, if you can't connect back to a human being in your organization to help that patient, then the technology isn't helpful. So I would say that would be the mantra that I go with. And then of course it comes down to practicality. What will I actually get funding for?
Got it. No, Gina, that makes a ton of sense. And I think the thing that you said that I keyed in on the most was that idea that you can't expect technology to solve all the problems. There's a really critical component of planning and figuring out, hey, what do we want to get out of this as an organization? And that planning or that phased approach to making sure that it's technology plus people is incredibly important. So thank you for that. Adria, how about the same question? How do you make sure that you're choosing the right technology for your team?
Well, I think probably the most important thing is obviously knowing our patient population and what their needs are. So here in downtown Indianapolis, we have a large population of Spanish-speaking and Burmese-speaking patients. So the ability to customize was very important to us as we look at different vendors and different software packages. We also have a large percentage of health illiteracy, so having technology that addresses that is extremely important. I think also what's going to increase our efficiencies is very important. How does it align with our current initiatives? Is it user-friendly? is it user-friendly for the staff as well as for our patients and families? I think the other thing is, what's the return on investment? So, making the business case in terms of, is this going to make an impact on patient satisfaction? Is this going to make an impact on readmissions, length of stay? And then I think, as Gina mentioned, the ability to pilot, I think, is very appealing, because you may think something's going to work in your environment, but until you actually try it and see the results, you really don't know. So that is certainly important to me. And then lastly, and which is another key piece, is just customer service and responsiveness. Especially when you're starting something new, it's really important to partner with the vendor and to make sure that, they're going to be responsive to your needs and the needs of others within the organization.
Adria, that's perfect. And the thing that I keyed in on there most was that idea of, does this cover all patients? Will this work for everybody? And I think that's a really critical function, as we hear more and more that health systems are looking for consolidation of vendors. The idea that you would have one system for your Burmese patients, but a different one for your Spanish-speaking patients and a different one for your English-speaking patients. I could understand the difficulty that could bring about. So I love hearing that inclusiveness of all patients is really a critical component of your selection process. So thank you for that. And finally, our last question today, what steps do you think other organizations should take to capitalize on payment reform, as we previously addressed, and overall to improve the patient care? And, Gina, we've gotten a number of questions related to DSRIP, so I know that wasn't initially listed as our payment reform models, but, feel free to address any items specifically related to DSRIP as well. So, Gina, why don't we go ahead and get started with you for that question?
Yeah, that's an interesting question because I think every organization is going to be at a different point depending on their market and how much of a pressure there is to actually start to invest in value-based care programs. I would say that this is really difficult work. So if you think about how we have traditionally approached healthcare, which is that patients come to us, we deliver care in a bricks and mortar building, and they go home. I think what we're beginning to recognize with these innovative programs is that it's in the home where healthcare really happens, and that there are a lot of barriers to people achieving their healthcare goals that have nothing to do with healthcare delivery, but have everything to do with the social structure, the circumstances they're in, their literacy, their impoverished state, or many, many, many other factors, including a lot of psychiatric and social and behavioral issues. And so I think as we learn about this part of patient care that we have not really had a lens on, that organizations have to recognize that this isn't something that you can just kind of shoestring. And what I mean by that is organizations have to be ready to make the investment. This is an infrastructure that for many places doesn't exist. And so I think that thinking about your priorities, and for us it started really with transitional care, because from an organizational standpoint it was around the Medicare patient population and trying to reduce readmissions, and I think a lot of hospitals have invested in that. But even us, we have invested sort of from an inside out. So I would say learn from our mistakes and just start from the outside, because that's where it all happens. When I say the outside, I mean outside of the order. And so this is where these technologies, patient outreach and engagement really make a difference, because patients are living with their chronic disease every day, not just when they show up to primary care or show up as an inpatient hospitalization. Because of the way that we've been paid over the last 30 years, that's what we focused on. And so it's a complicated question, but I think each organization has to take a space where they think it's most important to them, and then invest in it and learn from it. And as you start delivering care outside of the bricks and mortar, you'll be able to build more on that infrastructure. So, for example, we are now investing in home-based palliative care because there is no way for patients who repeatedly come back through the hospital that unless we have a palliative care and symptom management program in the home, that we're going to be able to affect that with phone calls or outreach or anything else. So you have to kind of understand the patient population that you're caring for, and everybody's patient population is going to be very different in their local markets and at their organization.
Perfect, Gina. And I love hearing that idea that it's an iterative process, one that builds on itself as you learn, as you understand your patients more and more. The scope of services that you deliver kind of grows right along with it. So that's really interesting to hear. Adria, same question. What steps do you think other organizations should take to capitalize on payment reform and improve patient care?
Well, so we all know that resources are tight, and our CFOs receive several different proposals, I'm sure. So in terms of our journey, it probably took us about 9 months of planning and writing business proposals to actually get our callback program approved. So I think having a very sound business plan with a great outline of what the return on investment is really important. I think garnering support from both formal as well as informal leaders will certainly help. I think the other thing is to make sure that you consider all of your stakeholders and garner support from them. Doing your homework, so not just that vendors are coming to you, but actually looking at what is out there, across the nation and even internationally that aligns with your initiatives, and looking at those best practices and doing your homework to really see, what vendor or software program or technology, whatever it may be, is really going to be best for your particular organization and your patient population.
Adria, that's great, and I love that differentiation that you just mentioned of the idea of buy-in, that there needs to be buy-in both from formal leadership as well as informal leaders. More often than not, those are folks that have been within the organization a while, that have that respect and that can drive a lot of the change that you're mentioning. So it's a really interesting dichotomy to kind of set up between those two different elements. So thank you so much for that. Folks, with that, I just want to thank you both, Gina and Adria, very much for taking the time to walk through this. At this point, we're going to hand it back over and begin to go for the Q&A from the audience. So with that, I think I'll pass it back to Carrie.
Thank you, Gina, Adria, and Alex, for a very informative and enjoyable presentation. As Alex said, we will now begin the Q&A portion of the program. As a reminder, you can submit any question you have, typing them into your control panel in the space labeled Enter Request for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during the time we have for Q&A. The first question we have coming in here is for Adria and Gina. How do you standardize the follow-up process? An organization as large and diverse as IU Health or UCF?
I'm sorry, you cut out a little bit, Carrie, so can you repeat the question?
Absolutely. How do you standardize the follow-up process for an organization as large and diverse as IU or UCSF?
Okay,
so, Gina, I can. Okay, go ahead.
Yeah, go ahead, Adria. Go ahead, Adria.
I was just going to say, so as it relates to, I'm not sure if this is the question or not, but our follow-up appointment program. So what we've done is we have asked for our interprofessional team within the daily digital to identify those patients that are at highest risk. We use the Boost tool to risk stratify our patients. And so anyone that is considered high risk, the case manager actually sends a referral over to our Care Alliance department, which is more of a clerical type staff. And then they will actually reach out to the different physicians. We usually start with primary care, but certainly if there is a specialty appointment that needs to be scheduled, they will go ahead and schedule that as well. And then they place that information on the electronic discharge instructions so that before the patient even leaves the hospital, they actually have their follow-up appointment, and we can validate that, yes, this is a good time for them to attend, that they do have transportation, et cetera. And if they don't, if there's a concern in any of those areas, then we use our case management team to assist in any way possible.
Gina, the same question on that front. How were you able to ensure a standardized follow-up process at an organization as large as UCSF?
Yeah, so we basically created standard work. So we're a lean organization, and our post-transitional care process, we ask the same questions for all patients, and then we have specific workflows and a specific process for onboarding each new service. So I want to say that we have been doing this now for 3 years, and we still have not implemented our phone call program in all populations, because each population requires its own escalation protocol, its own follow-up. And we're a tertiary quaternary medical center, so we have really sick, very specialized patients. So we've just created standard work. It can be done, and then we hold people accountable for it. And we're able to measure that adherence to standard work as well. So I hope that answers the question.
No, that's perfect, Gina. Thank you very much. Gina, this question is also directed towards you. It's in relation to the California State DSRIP program, and the question reads, how did you ensure your team would be able to deliver on goals outlined in the DSRIP program?
With much difficulty. I think that so the way that we set up our DSRIP program at UCSF, which was very, I really give credit to my the chief executive officer, is that we created a centralized DSRIP management with a centralized budget. So we were able to hold people accountable. We didn't just give the projects to somebody and put it on the backs of people already doing work. We also resourced it significantly for the projects that we knew would be a heavy lift. So I think we did a really good job scoping the project, understood what true change would be required, and resourced it appropriately. From in the state of California, those organizations who were not able to achieve, because some of these things were a heavy lift and were big infrastructure changes, some organizations, I think, felt that they could do it more on a shoestring and require that this work is just part of people's normal work. And when you're doing innovations work, it really does call for sometimes its own project manager, and oftentimes a pretty significant budget to get things up and running. And then once they are up and running, you can kind of pull back a little bit on the resources, but you can't underestimate the amount of resources it takes to make a change. And I think the organization also has to be committed to real change. Some of these things in the DSRIP program on face value look like they would be easy to achieve, but actually getting true performance and really measuring it and making measurable change oftentimes required a significant resource investment. And so we had committed to that, and we achieved 99.9% of the milestones and we achieved 99.9% of all the money.
Perfect. Thanks, Gina, for that. Adria, this next question is directed towards you. And the question reads, you mentioned analytics. Is there any data mining taking place that helps you profile patients for targeted interventions?
So using the Boost tool, it has interventions associated with each of the risk factors. We are working with our data warehouse team to try to create some analytics around that so that we really can identify who's at highest risk and really risk stratify them. I think Boost is a great tool, but the problem with our population, especially downtown, is that almost everyone scores in as high risk. So we're really trying to work with our analytics team to how do we weight those risk factors differently so that we really do know who's at highest risk for readmission, for mortality, for complications. So we continue to work with that team. And then additionally, we work with Evolent, and they are part of our IU health plan, so the insurance piece. And they have a platform that is called Identify that they actually look at so the number of claims, the number of pharmacy prescriptions that the patient is receiving, the number of admissions, whether those be ED admissions or inpatient admissions. They look at age, they look at comorbid conditions, and then they are able to risk stratify who's at highest risk. So our goal would be that we could do that for all our patients within IU Health and not just those within the IU Health plan.
That's perfect. Thank you, Adria. And in the interest of time, I think we're going to do 2 more questions, so one for Gina and one for Adria. The next question is directed towards Gina. Gina, you mentioned the use of technology to increase the reach of your programs, maximize resource utilization, and improve outcomes. How are you addressing the need for interoperability and data sharing across your organization?
That's a tough one. I think all organizations struggle with this because of the massive amounts of data that we feel needs to be collected on each patient. First of all, we across all of our hospitals, we use the same EMR platform, and the EMR platform is exactly that. It's the EMR, and so one by one, you have access to data. When you start to talk about population health and aggregated data and how do you share that, it's difficult. So some of the things we're doing is, and I think you have to understand, we can spend millions and millions and millions and millions of dollars on this sort of data analytics and integration. I personally, I have a great boss, and he always says to me, what are the 2 reports that you need to drive change? Because I think sometimes we become way too enamored of the fact that we can share data, and half the time people aren't even looking at it. So for example, we, as part of the first DISRIT program, we built an analytic, we built a series of ClickView dashboards that connect directly to, sometimes directly to Epic. They can connect to data warehouses. They can connect to existing Excel reports. So it's a really facile tool. But now that we're mature in these dashboards, what we find is that, and I think this is a really good question for all organizations, is that we've become so enamored of data and we spend so much time analyzing it and putting it together, and we don't give people the time to act on it, or we don't prioritize the data and let people know what it is we need them to work on. So I actually am going back to sort of the old-fashioned idea about how do you really affect change is really kind of back down to a human element. Now, I'm not saying we don't need data to some extent, but I think the pendulum has swung way too far the other direction, that we have so much data, we don't know what to do with it, and we spend tons of money and have huge infrastructure, and yet, you know, our mammography rates aren't moving. Our colon cancer screening rates are just kind of inching along. You know, back to analytics and targeting patients, nobody really knows what's the magic, you know, what is the magic formula for how you identify risk, and what kind of risk are you identifying? Are you identifying risk of readmission, risk of mortality, risk of utilization? And so I think all of these questions, we're getting a little caught up in healthcare, and I think this is where going back to some old-fashioned ideas about what do you really need to drive change, and focus on that data. So I don't know if that answers your question, but I think trying to understand who needs what data at what point is the most important thing, and then to recognize that we have over-inundated our providers and direct clinical people with data, and oftentimes it doesn't even sit together correctly or give the person the idea of the whole patient. So it's a really hard question, and I think I don't know if that answered it, but I would say that that's what we're struggling with as an organization. What data do we really need, and how do we get it into the hands of people, and then how do we which do we want to make a priority? Because right now in healthcare, it seems like everything's a priority, which then kind of deprioritizes everything, if that makes sense. And I'm sure many of you who are dealing with this understand that.
No, I think that makes a ton of sense, Gina, and I think it's that idea of a deluge of data leads to data inaction, which is really difficult for many kind of providers to deal with. So thanks for that response. And Adria, this last question is directed towards you. You have shared many innovative programs to enhance healthcare experience. What have you not yet been able to do for budget or resource reasons, but feel will be critical for further improvement?
That's an easy one. That would be transitions of care. So really looking at a lot of the work that Gina is doing. So really focusing on those high-risk patients and engaging with them after discharge, whether it's for 30 days or 90 days, to really get somebody into the home, again, whether it's a licensed individual or a health coach, reinforcing those discharge instructions, doing that home environment, that assessment of, okay, what other medications do they have in their cupboard, looking at safety issues within the home, looking at the availability of the caregiver, looking at needs and follow-up appointments, and, do they have transportation to get there? Those are all the things, as Gina alluded to, that, really, as she said, the care occurs when they leave our four walls. So how do we support patients better once they go home? We do try to use home health as much as possible, but we know that, not all patients have a skilled need, or not all patients are necessarily homebound that really could use a service such as that. So it was actually something that we proposed for our 2016 budget, but was not approved for this year, but at least I feel like some seeds were planted, and perhaps that we can move in that direction for 2017. The other thing that we're doing is we're looking at our internal resources to see if perhaps we could use them differently. So within the continuum, oncology, for example, could we have the same social worker see them in the oncology clinic as would see them in the hospital? So really trying to look at that full continuum until we can actually get the resources and the funding to develop a formal transitions of care program.
Got it. Thank you, Adrian. I think we have 1 minute left, and Gina wanted to respond to that question from the audience as well.
Yeah, so that's a really good question. I would love to do, and we're just now starting, is to do the home-based palliative care using telehealth. So as we look at our elderly population and Medicare population doubling over the next 20 years, and as we come to grips with the fact that a lot of the last 30 days of a Medicare beneficiary's life is their most costly period of time, we really have to build the infrastructure and really change the culture around dying. That it's okay to die at home around your family and have what is supportive care in the home to be able to do that. Not only will it be more cost effective, but I think patients will have a better experience than cycling through the ED and being admitted time and time and time again, which is very costly. So I'm really excited about the way that healthcare is going, that we are embracing these changes, and we have to be prepared as healthcare systems to build this kind of patient-centered, home-based care. And I'm excited because this is the roots of nursing, actually, was really starting in the communities and being in the homes. So it's exciting that both nursing physicians and other healthcare professionals and allied health professionals can be back in communities and back in the home, and that we can put structures together with technology that helps put the reach back into where patients are really experiencing healthcare, which is in their homes and with their families. So I'm very excited about this next era in healthcare, and I hope, what I worry though is that we are so kind of behind the 8 ball, because this silver tsunami is happening right now, and the elderly are an exploding population, and we really need to address it as a society and definitely as delivery systems.
Perfect. Well, with those two responses to a really good question, I just want to thank you both, Gina and Adria, for being such fantastic panelists. And I will pass the ball back to Beckers right now.
Thank you everyone so much for attending. This will mark the end of our webinar, and you should be able to see a recording of this within the next 24 hours. Hope everyone has a great day, and thank you so much to our wonderful panelists. Have a great week, everyone. Bye.